afternoon. I'm Sherry Binns, the Patient Healthcare Liaison for the Multiple Sclerosis Foundation. And we have as our guest speaker today, Dr. Thrower, who is our own Senior Medical Director for the Foundation. He is also the Medical Director for the Andrew C. Carlos MS Center in Atlanta, Georgia. And he's here today to talk to us about neuroplasticity and repair. And he's got some slides to show us, and then hopefully we will have some time to answer some of your questions. So Dr. Thrower, if you'd like to share your screen and put your slides up, I will jump off as soon as you have the screen up.
Wonderful. Awesome. Well, thank you as always to everyone at the MS Foundation for all of the hard work that you folks do to make programs like this possible. This, I think, is going to be a topic of great interest to many folks. When we think about how we manage multiple sclerosis right now, really everything that we do currently, you could put into one of three kind of treatment boxes, if you will. We're either treating relapses, we're managing symptoms, or we're hopefully preventing future issues, relapses, progression of disability, new MRIs, new lesions on MRI. But it feels like we are getting closer to that fourth treatment bucket, and that's reversing disability in multiple sclerosis. To me, that when people talk about a cure for MS, cure means different things to different individuals, probably largely based upon where you're at on your MS journey. But for many people, what a cure means is reversing the disability that MS has thrown at me. So we're going to focus on two things, neural repair and neuroplasticity. Repair would mean just that. I'm fixing the damage in the peripheral or central nervous system. That damage may have been caused due to injury, to inflammation, degeneration, stroke, or ischemia. Neuroplasticity is the concept of forming new pathways or rerouting. If you think of a roadblock, well, if I can detour around that roadblock, think of an MS lesion as a sort of a block in the electrical conduction of information, and we're going to find some way of rerouting around that area of damage. Regardless of whether we're repairing or rerouting, ultimately the goal is reversing disability and improving function. I mean, that's really what we're trying to do with repair and plasticity. So taking a step back to kind of set a level playing field, let's think about what multiple sclerosis does in the central nervous system, the brain and spinal cord. So what are we up against, and what are the strategies that are being looked at to overcome that? So the inflammation that we see in multiple sclerosis is driven by both B and T cells. This leads to the demyelination, or the stripping of the insulation of the nerve fibers, and also a cutting of those nerve fibers as well. The slide that I have up is a famous paper by Dr. Bruce Trapp at Cleveland Clinic from back in the 1990s that showed on the top, if you can see my arrow, so the green areas here are the areas of demyelination. And really, up until that pivotal paper, that's all we talked about with multiple sclerosis was the damage to the insulation of the nerve fibers or axons. And then what Dr. Trapp and his team showed very conclusively is that you also got this. This is a cut axon or nerve fiber, a transected axon, and this is something called a retraction bulb, where the axon is sort of pulled back on itself. And what Dr. Trapp showed is that this type of axonal transection occurred in MS, and it occurs early in multiple sclerosis. So we know that humans do have the potential to remyelinate. We can lay down new myelin, but this new myelin is actually thinner. It's not as structurally intact as the original myelin, and it's actually more prone to being re-injured with subsequent waves of inflammation. A newer concept, and it's kind of one of the hot topics in multiple sclerosis when we're talking about inflammation, is smoldering inflammation. And one of the ways that you might think of smoldering inflammation, if MS is a forest fire, smoldering inflammation is the embers that are left behind maybe after the big flames are out. So if you think of a forest fire, we pay so much attention to the big part, but even when that's gone, maybe there is this low level simmering, smoldering inflammation that's just under the surface. We're going to talk about microglial cells as a cell that is where a lot of research is focusing, that may be the driver of some of that low level inflammation or smoldering inflammation. Research is now pointing towards B cell follicles. Normally, we think of the inflammation with MS as being driven from outside of the brain and these inflammatory cells crossing the blood-brain barrier and now causing damage in the brain. But there is good evidence that over time, inflammation actually sets up in the brain itself. So there's these little nests or follicles of B cells on the covering or the meninges of the brain that can now drive chronic inflammation. So microglial cells, again, the focus of a lot of research recently. Normally, microglial cells are good guys. They're sort of like the brain and spinal cord's garbage men. They go in and clean up old damage, maybe clean up precancerous cells. They can clean up damage due to inflammation or injury. But it looks like microglial cells can also become bad guys and actually contribute to this chronic smoldering inflammation. So some of the unique challenges with multiple sclerosis, as in contrast to say other types of injuries to the central nervous system. So when you think about other problems where we would like to see neural repair or plasticity, think about spinal cord injury, stroke or brain injury. These are one-time events. They are, so whereas MS, we have this ongoing inflammatory attack on the brain. With these other conditions like spinal cord injury, you have a one-time event. With these other events, they typically are one site of injury. So at Shepherd Center, where I'm at, whereas I focus just on multiple sclerosis, the rest of the hospital is working with spinal cord injury and brain injury, and they are doing research on neural repair and neuroplasticity. So I would argue that sometimes their challenge may be a little more straightforward in that they have this one site of injury, one time event, and it's not an ongoing process. So when we think about the peripheral nervous system versus the central nervous system, one of the mysteries is, why is the peripheral nervous system so much more capable of repair than the central nervous system? One of the things that we think maybe sort of limiting some of the repair that we see in the brain and spinal cord are intrinsic inhibitory factors. So there are cells, and I'll use my arrow here. There are cells in the central nervous system called OPCs, oligodendrocyte precursor cells. Oligodendrocytes are the cells in the central nervous system that make myelin. Before they become myelin producing oligodendrocytes, when they're immature, they're called OPCs. Well, it turns out in our central nervous system, we have populations of these OPCs just sitting there waiting to do something. Why aren't they repairing? Why aren't they sort of coming in and remyelinating? Well, one of the reasons they may not be are intrinsic inhibitory factors like no-go. No-go does exactly what the name sounds like. It tells the OPCs, don't become oligodendrocytes. No-go is part of a bigger complex called LINGO. And we'll circle back to this when we think about possible treatment avenues for neural repair. So one of the other challenges with multiple sclerosis is that around these areas of demyelination and axonal transection, we get something called gliosis. Think of gliosis as sort of like concrete or scar tissue. So you get this scar tissue that forms around these areas of demyelination and axonal damage, and it makes it really difficult for for remyelination to occur, because the repair factors can't get to where they're supposed to be because of this sort of, a scar tissue or gliosis. There are also sort of genetic factors potentially at play. There's something called RAGs or RAGs, regeneration associated genes, that would like to help our body sort of remyelinate and repair damage in the central nervous system. But it appears in multiple sclerosis that may be some sort of inhibition of these regeneration associated genes. So when we start thinking about, so those are the challenges that we see. How are we going to overcome those challenges? An area of lots of interest, and I apologize for the beeping in the background. I have construction right outside of my window. Um, One of the areas of quite a bit of interest would be stem cells. And there, when we say stem cells, we're really talking about a number of different potential things. One would be neural stem cells. So these are cells that can be derived from fetal tissue. There is a way of taking cells from the individual themselves and actually in the laboratory reprogramming them. So when we say allogeneic, that means we're taking the cells from the patient themselves. So there are ways in the laboratory of potentially reprogramming cells to start acting like neural stem cells that can become sort of other parts of the central nervous system. Probably a more commonly researched area would be mesenchymal stem cells. So mesenchymal stem cells can be found in a lot of different tissue, from fat to skin to just any number of body types. And I think a lot of the research that we're seeing in multiple sclerosis right now are focusing on these types of cells. We're going to take just one little detour and mention autologous hematopoietic stem cells. Actually, let me go back I misspoke here. Allogeneic is not from the individual themselves. These are from donors. I should clarify that. So allogeneic is from another person. Autologous would be from the patient themselves donating the tissue. So this is a different type of stem cell procedure. This is basically a bone marrow transplant. This would be a rebooting of the immune system, if you will. Technically, it's not a repair strategy. It's not really a neuroplasticity strategy, but some of the studies with autologous hematopoietic stem cell transplantation have shown some reversal in disability. It may be that improvement in disability that we see with this procedure is due to the dramatic quieting of inflammation, and maybe this lets natural repair mechanisms take over. The idea with this procedure is that we're going to take immature cells from a blood sample. These are immature cells that can become any part of the immune system. We're going to save those cells and freeze them. We're now going to do something called immune ablation. We're going to wipe out the existing immune system with chemotherapy, sort of shut down that inflammatory response. And now we're going to give you those immature stem cells back, and we're going to reboot a fresh immune system, an immune system that doesn't have the ability to attack myelin and damage axons. So thinking more of the reparative stem cells, which I think is more the focus of today's talk. One of the questions is, how do they work? What do they do? I think there was a suspicion in the past, and this was largely based upon what neural stem cells do, that mesenchymal stem cells maybe differentiate into cells in the central nervous system. Maybe they become neurons or they become oligodendrocytes. And it turns out that's not the case. They are not differentiating into cells in the brain and spinal cord. They really appear to work by secreting nerve growth factors or other anti-inflammatory chemicals or cytokines, and that then those are the actual sort of reparative mechanisms through which mesenchymal stem cells work. It's not even clear that these mesenchymal stem cells have to get into the central nervous system. We'll talk about one of the studies that we're doing here at Shepherd Center and why we think that maybe these cells don't even need to get into the brain to do their thing. One of the areas of very early research that's being done is if mesenchymal stem cells don't have to actually sort of become the cells in the central nervous system, if they're really working but through these nerve growth factors or anti-inflammatory cytokines, why don't we just focus on this? Why don't we try to isolate these and use that and skip the mesenchymal stem cells? So that type of research is being done at places like Cleveland Clinic. So how do we give stem cells? Really three routes of administration. Intrathecal, this would be putting them into the spinal fluid, like through a spinal tap. Um, and the idea is that maybe these cells, these mesenchymal stem cells, are then drawn to sites of inflammation where they secrete these sort of growth factors or cytokines and hopefully promote repair. A more aggressive way of giving stem cells would be intraventricular. So this is actually doing a small sort of hole into the skull after the person is has some anesthetic put there, and through a small catheter, these cells are then given directly into the brain's plumbing system or ventricles. Um, the last way and the easiest way would be to give them intravenously. So again, it's not clear that these cells actually have to cross the blood-brain barrier. They may be able to work peripherally. And some of the one of the studies that we're doing here at Shepherd Center, the cells that we're doing are given intravenously, and it appears they actually set up shop around the lungs, which is very interesting, and then secrete their growth factors or their anti-inflammatory cytokines, from that peripheral site from the lungs. That growth factor or cytokine crosses the blood-brain barrier, and that's how these cells are actually working. So these are a few of the studies that have been completed, and it is a mixed bag with some success and others maybe not as successful. So there was a study in 2020 looking at 48 individuals with active progressive MS. So this is secondary progressive MS where there is still either new lesions on MRI or relapses. And these folks were randomized to either receive the IV stem cells, intrathecal stem cells, or a placebo, a sort of a sham infusion. What they did see is that with the stem cell infusions, be it IV or intrathecal, that there were some improvements in disability as measured by the EDSS. There were some improvements in time 25-foot walk, 9-hole peg test, and an OCT, optical coherence tomography. This is a way of measuring the retinal nerve fiber layer very quickly and very simply. And this retinal nerve fiber layer, is measured by OCT, does correlate with brain volume. So it's a kind of an interesting sort of surrogate measure for brain volume. There was a 2021 study of 144 individuals who received mesenchymal stem cells intravenously compared to a placebo group, and this was a negative trial. So they were actually looking at active inflammation as measured by gadolinium-enhancing lesions on MRI. And in this study, they really did not see any difference between those getting stem cells and those getting placebo. This was a very interesting study, a very aggressive way of using the stem cells. These were cells given intraventricularly, so that surgical procedure where a small catheter is put through a hole in the skull, and these cells are given directly into the brain's plumbing system or spinal fluid. So it was small, 12 individuals. These were people with either primary progressive or secondary progressive MS. There was no placebo group. Everyone got treatment. The results were mixed. They did see a slowing of brain atrophy. They measured brain growth factors. These were increased. Disability unfortunately didn't get better. It actually got a little bit worse. And what they saw is that there were still new lesions forming in about half of the individuals. So again, I think the jury is out on this. Should certainly prompt more research. Again, this is a very aggressive thing to do, given that the cells are being given into the ventricles themselves. So this is the study that we're doing here at Shepherd Center, along with Rocky Mountain MS Center in Utah and UMass Hospital. So this is an early trial, a phase 1 study. These are human embryonic derived mesenchymal stem cells. So these would come from couples who were doing in vitro fertilization. With that procedure, you're sort of fertilizing, a large number of eggs, ending up with a lot of sort of embryos, and these couples are only going to use, so many until they have a successful pregnancy. Though the remaining frozen embryos are typically destroyed then. And so these were individuals who donated that tissue that was going to be destroyed to research. And so these cells were actually derived through researchers at the University of Connecticut. They then set up their own biotech company called MStem. And so these cells are given intravenously. There is no placebo group with this study. So everyone gets the cells. In the first arm, the certain dose of the IV stem cells were given. In the second arm, a double dose, so twice the first dose. And then there is going to be a third arm where we're going to do 2 double doses. Right now, there's been some difficulty with procurement of the cells, so we are on a pause right after arm 2. So this trial is ongoing. We know how our individuals here at Shepherd Center have done in terms of effectiveness. We don't know how the individuals at Rocky Mountain or UMass have done. We know that there have been no safety issues whatsoever. So they would have to ethically report safety issues. And I would say within our individuals, it has, so far from what we've seen, because we're unblinded, we know these people are on treatment. It's been a mixed bag of some people seeing benefit and other people seeing nothing, but no significant side effects that we've seen. So what are some of the other ideas? So there certainly is a lot more going on than just stem cells. And the answer ultimately could come from something other than stem cells. A lot of people believe that it will come from something other than stem cells. So this is an IV monoclonal antibody that has been researched called opicinumab. If you remember back when we talked about some of the barriers to natural remyelination in humans, one of those barriers is this no-go as part of lingo. Again, no-go that lives on the lingo complex tells the oligodendrocyte precursor cells not to mature into oligodendrocytes. So what opicinumab is it is an inhibitor of the inhibitor. So it's going to hopefully block no-go on lingo and let these OPCs become oligodendrocytes and remyelinate. There have been mixed results to date from 2 phase 2 studies. There is some question that the dosing may have been adequate. So I think there is a good chance that there will be more studies, in the future looking at this option. The treatments were very well tolerated, no significant side effects. So Clemastine has had an interesting journey. So when we talk about Clemastine, we should step back and talk about some of the larger research that's being done at UC San Francisco. So this was research largely funded through the National MS Society. What they wanted to do is come up with a test tube model that would allow for the rapid screening of molecules that might have the potential to regenerate myelin. And what they came up with is a micropillar. A micropillar is a fake axon, a sort of synthetic axon in a test tube that you can grow myelin on it. So what they do with this model is they in a solution that cells can grow in, they put those OPCs, the oligodendrocyte precursor cells, into that solution. So you've got the cell, you've got your synthetic axon. Now something has to turn that OPC on and say, go, make myelin, become an oligodendrocyte. So what they're doing with this model is really throwing the kitchen sink at it, putting FDA approved molecules in there just to see if by luck they might regenerate myelin. So the beauty of this model is if something works, it's already FDA approved. We know it's safe in humans. So in theory, if something, it's going to let that research progress a lot more quickly, because you don't have to do animal models, you don't have to do human safety trials. We already have that information. So there was a phase 2 study of 50 individuals with relapsed or remitting MS who had residual visual loss from prior optic neuritis. They treated all 50 of these individuals for 6 months with oral clemastine. Clemastine is the active antihistamine ingredient in Tavist. So it's been around for a long time. Why would an antihistamine repair myelin? We don't know. So this is kind of a reverse way of doing research. We want to see if it works, and then we'll figure out how it works later. The real question is, does it work? So what they saw in the 50 individuals with visual loss from optic neuritis is that all 50 had some improvement in their visual acuity and in their visual evoked response. So this is a test that measures how long it takes that electrical information to get from the back of your retina to your visual cortex, your occipital lobe, and it's sped up in these individuals after the clemastine, which would be a strong argument that they are remyelinating. There's been a follow-up study using some more sensitive MRI techniques on these 50 individuals, and there was evidence of remyelination on these more sensitive research MRI techniques. That's the good news. Maybe the not great news was another study looking at people with progressive forms of MS, and they did stop that study early because there was worsening of disability in some of these individuals. So I think we've still got some work to go. Along with this type of research, there are trials also looking at metformin, the drug that's been around for oral drug that's been used for diabetes, and there are some combination studies going on putting clemastine and metformin together. So vidofludimus is an oral agent that is being looked at. It seems to have a lot of different properties. It looks like it's neuroprotective, anti-inflammatory, and antiviral. There is some hope that it may have repair properties. And so there is a phase 3 study in both primary and secondary progressive MS. The study's called Caliper, looking at this oral agent. This is one that got a little bit of media attention within the past month or so. So this is an agent called PIPE 307. The study is called VISTA. So this is an oral agent that blocks a receptor on oligodendrocyte precursor cells that appears to inhibit them from becoming oligodendrocytes and repairing myelin. So it's different from Antilingo and the no-go. So this is a different inhibitory sort of receptor. It's called M1R. So again, this is an oral agent that appears to block that M1R receptor. It has been successful in the mouse model in remyelinating. There was a phase 1 human study that looked at dosing and showed that it was safe and it was well tolerated. And now there is a phase 2 study that is ongoing with this molecule to see if we are going to see remyelination and reversal of disability in multiple sclerosis. So this is another avenue that I think we'll see pursued. So vagus nerve stimulators are not new. So the vagus nerve can be accessed in your neck. Vagus nerve stimulators have been used for refractory epilepsy. So if you have a seizure disorder and maybe you're on 1 or 2 oral medications and you're still having breakthrough seizures, this device can be surgically implanted. Looks like a pacemaker, and it's usually surgically implanted up around the shoulder area, and then small electrodes tap into that vagus nerve in your neck and send signals upstream to the brain and inhibit seizures. Well, it looks like this device could do more than that. It may look like it improves remyelination. There are animal models that have shown this. It looks like it may be anti-inflammatory by reducing some of these microglial and astrocyte activation and that's causing damage and smoldering inflammation. So I think there is a good chance that we will see some phase 1 and phase 2 human studies. The FDA has looked at the data we have so far from an animal standpoint and has sort of given the green light to move ahead with human trials. So this is a stay tuned. So shifting a little bit over to neuroplasticity. So again, this is the kind of the rerouting, if you will. So I would mention it's maybe not quite as exciting as some of the things we've talked about before, but please don't forget the role of exercise and rehabilitation. There are clearly exercise and rehabilitation will improve function for many people. It may in part be due to neuroplasticity. We may be helping people form new pathways to sort of get around those areas of damage and improve function that way. One of the devices that is now FDA approved that kind of speaks to neuroplasticity is this Helios PONS unit. This is a neural stimulator. I don't know if you can tell in the picture. So she's actually wearing this device around her neck, and then you have this little sort of wire that comes off that ends in a gold-plated electrode that is sitting on her tongue. And so this device is used during aggressive rehabilitation. What studies have shown that if we take two groups of individuals with MS, both groups get aggressive rehabilitation. One group does not wear the device, one group wears the device. Both groups showed improvement from the rehabilitation. The group that wore the device actually had more improvement. So there is a suggestion that it's doing this by sort of forming these new pathways. Some of the challenges to using this are the rehabilitation is aggressive. It's a lot of physical therapy, and there the company Helios will train physical therapists out in the community. I think it's going to be tough for a physical therapist who doesn't see a lot of multiple sclerosis to justify getting the training done. We did a study with this device. We did see improvements in function. Ideally, we would like for people to continue using the device with home exercise afterwards. The device is not inexpensive. It's about $23,000. And to date, we have not had any success getting an insurance company to cover this. So I think some of the real world challenges we're going to see is the amount of rehabilitation that's required, and then how do we get these devices paid for individuals. So I will finish up by saying, these are all exciting things that I think are on the very near horizon. I do think we will have that fourth bucket of treatment option for MS that would improve function through either neural repair or neuroplasticity. In the meantime, don't just keep your eyes on the horizon. Do everything you can right now to maintain function. Be as aggressive as you can with your wellness, your exercise, your rehabilitation, to try to maintain function as much as we can. If you are, would benefit from being on an appropriate disease modifying therapy, please, keep that in mind also, because I think the less disability we have for the future, I think the more likely it is, and the lower the bar is for you to sort of improve function as we get more options in the future. And with that, I will stop. Again, I apologize for the construction in the background, and I will turn it over to Q&A.
Okay, Dr. Thrower, is there any chance you can stop sharing your screen?
Yes, let me.
I can do it.
Okay, thank you.
All right, thank you. We had one question emailed to us from Jennifer. She also ticked it into the chat. She says she's got tumefactive MS and have had active tumors lighting up on MRI for 2 years now with symptoms. Do you have, let's see, do you have anyone at Shepherd Center with this diagnosis? And if so, have any treatments helped? And what would you recommend? I can't find anyone with the diagnosis, and I've joined tons of MS groups. What are your thoughts on tumefactive MS? But also in the email, I should tell you, she has just finished her second round of Lemtrada.
Okay. So
Okay.
just for the rest of the audience, so tumefactive MS is a less common form of MS. It is a very aggressive inflammatory form of MS. And the reason they call it sort of tumefactive is it kind of looks tumor-like on initial MRI. And some people actually have their tumefactive MS diagnosed by biopsy because someone thought it looked tumor-like, and so they ended up getting a brain biopsy to make the diagnosis. It is an uncommon form of multiple sclerosis. As she said, it is very inflammatory. I don't know that we know what the best treatment is because it's so uncommon. It's not like you can show a trial of 1,000 individuals, in a randomized placebo-controlled trial. I think we want to use aggressive anti-inflammatory treatments. I think Lemtrada, alemtuzumab is perfectly reasonable for something like that. We had an individual years ago that we treated with an aggressive course of mitoxantrone or novantrone. That's an old immunosuppressant drug. It is FDA approved for MS, but you would be hard pressed to find anyone using it now because there's some significant side effects with that drug. We always knew about the cardiac toxicity, but we didn't appreciate that there was a significant risk of an aggressive form of leukemia with that drug as well. So it's really not used very often. I think other things that you would see used would be any of the B cell therapies. So, anything from rituximab, ocrelizumab, Briumvi, Kesimpta would be thoughts. But I think Lemtrada is perfectly reasonable as the next step.
Okay. Alyssa says, my hopes are pinned on NerveGen. What do you think about NVG-291?
So I know, so just for the audience too, like we talked about pipe 307, anytime, we see something that is letters and numbers, it's very early on. And so, by definition, when we see something like that, it's going to be a phase 1 or maybe a phase 2 study. And so there has been early promise with that. I would say it's kind of like where we're at with pipe 307 in that I think we just need to wait and see. These are all things that have shown promise in the animal model. So usually to get to a human trial like a phase 1 or phase 2 study, it probably showed benefit in that mouse model for remyelination. The challenge obviously is that the mouse's immune system and central nervous system is not a human one. And so there have been examples of things that have worked in that mouse model that have not translated into humans. So yeah, I think it's very early. We're excited. I think really, where I start getting very optimistic is when we start seeing completed phase 3 studies. Ultimately it's going to be the phase 3 study that's going to get something FDA approved. And so I think we always want to have that balance of cautious optimism. I would discourage people from going down the rabbit hole of animal studies only. Again, that you can really get into the weeds looking at something that's only animal studies. At least wait until it has a phase 1, phase 2 human trial before it sort of shows up on your radar.
I think a lot of people don't realize that it takes up to 15 years on average to go from phase 1 to FDA approval and availability to the public.
Yeah.
So when you're reading something about a phase 2 trial, you've still got another decade to go.
Yeah.
Just realistically.
And we
Uh,
want to be optimistic, but like you said, realistic at the same time. And when you look at it, like you said, from concept to FDA approval, like you said, about 15 years, and the failure rate is unfortunately pretty significant.
yeah, I've heard on several occasions that out of every 100 drugs that goes into trial, only one makes it to FDA approval. So
I think what gives me hope also in neural repair and plasticity with MS is it's not just us that are working on it. The spinal cord injury docs, the brain injury docs, they're working on it as well. And something that works in spinal cord injury could just as easily work in MS. Again, there are things that we might look at in spinal cord injury that might not apply to MS. We were doing studies here at Shepherd with surgically implanting cells into the side of a spinal cord injury. We probably wouldn't want to put a needle and implant cells into every MS lesion. So that might not be practical, but if it was something that was put in intravenously or into the spinal fluid, I think that certainly would apply to MS as well.
Okay, thank you. Karen has her hand raised. Karen, I have allowed you to talk. Could you unmute and ask your question, please?
Yes, thank you. Doctor, of all these studies, if any of them succeed, might my heat sensitivity be diminished?
I think, anything is potential. So any area that is repaired or remyelinated, you would think that, because heat sensitivity really is nerve fiber fatigue. You're heat sensitive because your demyelinated nerve fibers stop working when you get overheated or overexerted. So if you remyelinate those, we certainly would think that that should get better. I think what you're going to see in a lot of these neural repair trials is they sometimes may focus on something, a very specific symptom, like that Clemastine study focusing on vision. Vision's very appealing to focus on in a repair study because it's so objective, it's so focused, it's easy to measure it. That doesn't mean that something that worked in a visual study wouldn't work for, say, heat sensitivity or walking or cognition. That's just what they picked to study. But our hope is that these repair strategies will have pretty broad, areas that they would improve.
Thank you.
Did you remute yourself, Karen? Thank you. Jamie says, if you're taking Ocrevus or Kesimpta, does damage or inflammation keep occurring or does it stop?
Yeah, that's a wonderful question. So with any of our disease modifying therapies, and I would argue that the B cell therapies like Ocrevus and Kesimpta and Briumvi and rituximab are really amongst the more effective things we have in the toolbox. Right now, our goal is an acronym called NEDA, N-E-D-A, no evidence of disease activity. So that means you have no new MRI lesions, you have no progression of disability, and you have no relapses. That's, for right now, is we would consider to be an A on your MS exam. But is it really? Is the smoldering inflammation below the surface, is it something that is still ongoing and we're just not aware of it? I think the jury is still out. I think smoldering inflammation is real. I don't know that we have a perfect way of measuring it and telling, who all might have that. So I do think our B cell therapies, like you mentioned, are very, very effective. And we have a lot of patients on B cell therapies, other effective drugs like natalizumab, who appear to be stable by every measure that we can look at. They don't seem to have any ongoing active inflammation, the best we can measure it. They don't have relapses, they don't have new lesions on MRI, but I think we want to continue to push that envelope and say, are we really as stable as we can humanly be?
Thank you. An anonymous attendee says, are there age limits for stem cell treatment?
So in research, there are always limits, and that's frustrating. So there's always a battle between what the MS community, what people like us that, advocating for the MS community, we want the trials to be as open as possible. A pure researcher is going to want the trial to be pretty narrow. So in research, there are inclusion and exclusion criteria. Along some of those, inclusion criteria are going to include age ranges. So when we think about what might keep someone out of an MS trial, it's usually either going to be they're too young or too old. In the past, MS trials in adults were 18 to 55. Now we see 18 to 65, commonly. I hope that age range, because we're getting healthier as we get older as a population. I'm hoping that upper age limit goes up. We do see disability sort of ranges. So they'll say we want an EDSS as a measure of disability between these things. A lot of times they set that upper limit of disability at an EDSS of 6.5. That means you have to be able to walk some with something like a rollator or bilateral assistive devices. And then the type of MS that you have, sometimes they're only want people with relapsing forms, or primary progressive or secondary progressive. So there are all those factors that go into whether you can participate in a certain trial. Now, if something is FDA approved, then the gloves are off. Or if we're using it off label in a say that someone wanted to try Clemastine off label. That's between you and your healthcare provider, and there really would be no limits in that sort of off-label use.
Thank you. Melina says, are there clinical trials for MSC therapy?
So what MS?
Mesenchymal stem cells.
Yeah, so there are a lot of ongoing studies, and I did as much of a literature search and went on clinicaltrials.gov to see what was out there. I know that there are some small single site trials. I know Dr. Sadiq in New York has been very active with a lot of mesenchymal stem cell trials. So what I would encourage people to do, because it changes all the time, is if you want to know what trials are recruiting, you can go to clinicaltrials.gov, put in multiple sclerosis stem cells, and it'll show you both ongoing trials and trials that might be recruiting. The National MS Society website sometimes has, if it's a big national trial, they'll sometimes put little blurbs about trials that are actively recruiting. And then just talking to your local healthcare providers to say, hey, have you guys got anything that's going on? It's sometimes worth asking your healthcare team, how would you know if I was a candidate for your study, and see how they actually screen people. So for instance, here, what our clinical research coordinators do is so they all have their trials. They will go into our patient list at the beginning of each day or the day before, and they set the parameters for what each study is looking at, and they screen every patient that we're seeing on every day and say, is Mrs. Smith a candidate for this study? If someone is a match for a study, then they contact that neurologist and say, hey, I'm thinking about Mrs. Smith for this trial. What do you think? And then we go from there.
As a follow-up on that, somebody in the chat, Krista, is asking, for all the studies that you mentioned, were the participants also taking DMTs as well at the same time?
Yeah, good question. It's a mixed bag. In some studies they are allowed to, and others they're not. Some of the non-stem cell studies that we mentioned, some of those oral meds are being added to your existing disease modifying therapy. In contrast, if you look at the MSTEM study, the mesenchymal stem cell study that we're part of here at Shepherd, you specifically cannot be on a disease modifying therapy. So that it's going to be a mixed bag. I would be very uncomfortable taking someone off of their disease modifying therapy to participate in a clinical study. I just ethically, I wouldn't be okay with that. We're pretty picky about studies that we sign up for. And I know most MS centers are. You have to. There's a balance between how much risk you're exposing a person to and what potential benefit they get. And one of the unwritten rules that we use here, and I know a lot of centers do, is if I wouldn't have my own family member participate, we're probably not going to sign up for that study.
Thank you. An anonymous attendee asks, what is the best DMT for non-active SPMS while I wait for these other treatments to be approved?
Yeah, that's a tough one, because technically, if you look at everything that's out there, there technically is no FDA approved treatment for non-active secondary progressive MS. Most of our treatments, so Ocrevus is approved for relapsing forms of MS and primary progressive MS. Most of our other drugs are approved for relapsing forms of MS, whereas non-active secondary progressive MS is by definition not relapsing. Does that mean we don't treat you with something? No. This is where things get into the gray area and that shared decision making between you and your healthcare provider. We do use things off label. what thing you might use off label. I think that's going to be between you and your healthcare provider. There is evidence that even though you say we label a person as non-active secondary progressive, does that mean there's absolutely no inflammation whatsoever? Probably not. There's probably still inflammation, and I still think there's a chance the person benefits. It's just that we haven't been able to show it in a phase 3 study yet. Largely, we haven't been able to show it because we've excluded a lot of people with non-active secondary progressive MS from studies. So there's been selection bias. So I think the same highly effective therapies that we might look at in other forms of MS, B-cell therapies, natalizumab, Mavenclad, cladribine, I think that those are worthwhile discussions off-label between you and your healthcare provider.
I just want to give you a heads up that we've got more than 50 questions waiting in the
I
queue.
better be shorter with my answers.
For those of you who are asking questions or awaiting answers to questions, if somebody has asked a similar question, I may not be reading out your question. And if you don't get an answer to your question, respond to your registration email with that question, and we'll get an answer for you.
So here's a thought, just I'll throw something out. Maybe for next month, maybe rather than doing what we might have had planned, maybe we do a part 2 to this if we really have that many questions, and we just said part 2, neural repair and plasticity, and make it just purely a Q&A with that as the focus.
Would be great. I do have Sherry from Facebook asking, she says, this is my second year of Mavenclad. I was on Tysabri for years. How long will my immune system be compromised after taking Mavenclad?
So the cell counts really bounce back, pretty completely within 6 months of a Mavenclad dose. Maybe some people a little longer, some people a little sooner. And it looks like when those cells come back, both the B cells and the T cells, they're kind of reprogrammed, if you will, to be less inflammatory. So what's interesting with Mavenclad is even when the cell counts are low, after one of your doses, we just have not seen a lot of infections with that drug. I'm not sure that I can completely explain it. But the safety profile, even though it is decreasing cell counts, it appears to be pretty favorable. So the numbers of cells seem to come back by 6 months mark or a little later, but the actual clinical immunosuppression in terms of infection risk appears to be pretty low, even when the numbers aren't there.
We did hear at the Consortium of MS Centers annual meeting this year that there are now studies, look back studies on the effectiveness and of Mavenclad, and we're seeing people going 15 years with no new disease activity.
Yeah.
Geraldine says, my sister has primary progressive MS. Can you tell me a little about Lemtrada? Her doctor wants her to do it, but I'm scared for her.
Yeah, so I mean, it would be off-label. So Lemtrada is not FDA approved for primary progressive MS. Again, but technically our only FDA approved option would be ocrelizumab or Ocrevus. I don't think that that's a completely unreasonable thought. Lemtrada does have, side effect risk. It is an immunosuppressant drug. It's going to knock those B and T cells down for a while. I don't think it's a crazy idea. I think you just want to, if you're going to go that route, you want to go into it with your eyes open. One of the challenges with Lemtrada is once we give that drug, we don't really know what we can give after that drug safely. So I would probably, if the person had not been on a B cell therapy, I would probably look at that first, because you could always say, well, I'm going to try a drug like Ocrevus, it's FDA approved, try it for a year. If I don't see a response there, then I'll look at something like a Lemtrada. Whereas if I do Lemtrada first, I may not be able to give Ocrevus later. Just a thought.
We have, let's see, I just scrolled past the individual's name. Jane says, no DMT for primary progressive, no active lesions, 71 years old. Where can I find aggressive PT for MS in Arizona?
Yeah, so I mean, lots of different resources. You can certainly use the National MS Society and the get names of referral from local physical therapists there. I would lean on your local support groups, whether it's through MS Foundation, MS National MS Society. Talk to your local people. Say, who do you guys use? Who do you like? Because just like not all neurologists are the same, some specialize in MS, some specialize in stroke or migraine. Physical therapists have different areas of specialization, and there are going to be some who are very comfortable with MS and others who are not as much. So yeah, National MS Society support groups would be my recommendations. Sherry, I don't know if you have other resources.
Dr. Herb Karpatkin is also on our medical advisory board, and he does an Ask the MS specialist every couple of months. If you want to email me at Sherry, that's CHERIE at msfocus.org, I'll send you his email. He has said multiple times in the past that he will help somebody find an MS specialist in rehabilitation near
That's a
them.
great resource.
Okay. I've got from Dinah on Facebook, or Dina, I'm not sure which. Do any of the therapies help with cognitive dysfunction besides the visual urinary issues? That is my main MS issue.
So we really don't think of disease modifying therapies as necessarily helping with something. They're more of your insurance policy to help prevent future problems. You know, when we look at cognitive dysfunction in MS, I mean, we want to sort of peel that onion layer back a little bit and make sure we're not dealing with other things. Fatigue can certainly contribute to cognitive issues. Mood disorders can contribute. We rely quite a bit on our speech language therapists for cognitive rehabilitation to help with people sort of navigate cognitive dysfunction and hopefully improve upon their cognitive function. I am not blown away that I have a great prescription medicine to help with cognition. There were some small studies many years ago looking at Aricept, donepezil, Alzheimer's drug. There was a little bit of positive there, but I'm not blown away with it. So I would look at sort of managing fatigue and mood if those are contributing, and then getting you in with a speech language therapist.
Okay. An anonymous attendee says, can a person with MS go from Aubagio to Copaxone without a washout period? I need to change due to side effects.
Yeah, I'm comfortable with that transition. So they have very, very different mechanisms of action. Aubagio or teriflunomide has a half-life of forever. So if you've been on Aubagio and we stop it and we look for the metabolite leflunomide in your system, we may still measure leflunomide in your system, 6 months, 9 months, a year later. If we need to get rid of the leflunomide quickly, there is a rapid elimination protocol using either activated charcoal or cholestyramine. But because the mechanisms of action between glatiramer, Copaxone, and teriflunomide are so different, I would be comfortable with no washout between those two.
Okay. Jonathan asks, what are your thoughts on frexalimab? Frexalimab. I'm not
I am not
familiar with
familiar
that.
with, yeah, I'm not familiar with that one. Maybe we'll have to circle back and get an email. I'm not familiar with that one.
Karen says, if there is no objective improvement with a B-cell DMT, only NIDA, why do relapsing remitting patients talk about the crap gap a month before 6-month infusion?
Yeah. So I think we definitely see a crap gap with natalizumab. I mean, that's where we first saw it, but we do see it with B-cell therapies also. And I think the good news is I don't think it's actual disease progression. I think when people describe that not feeling great, let's say 5 months into their dose of ocrelizumab, it tends to be just that, feeling crappy, fatigue, maybe a little just achy, maybe a little weaker. But I don't think I've ever seen someone have new lesions on MRI or true relapse type symptoms. I don't know that we know what drives that. It could be that when we measure the B cells in on a blood test, and even though they're suppressed typically, so the CD19 is a marker of what the B cells are doing, are usually 0 before your next dose. We've got to realize that blood test is only measuring 2% of what's actually in your body. Most of your B cells are out in the tissues, and maybe it's that the B cells in the tissues are starting to creep up a little bit, and it's just not reflected in the bloodstream. Maybe that's what people are feeling. I don't know that we know. I think we can guess at what it is, but yeah.
I think this is going to have to be our last question. We're now over 60 questions in the queue. But Sonia says, I'm interested in cell therapy. I'm looking at going overseas. Is there a particular type that you'd recommend for somebody with primary progressive MS?
So I would just say be a very smart healthcare consumer. Do your research. There are a lot of scammy stem cell clinics overseas. And so when we think about the mesenchymal stem cells that are being given in research, these are not things that you can just do a blood draw on somebody and magically get mesenchymal stem cells. These are very difficult cells. They have to be, sort of sometimes manipulated in the laboratory. So just be cautious. I would say if that clinic is making claims, it would be wonderful if they have a published peer-reviewed study to back up what they're claiming. Other little red flags, if you look at their brochure or their website and they say they're treating MS and Parkinson's and Alzheimer's and autism, that should be a little bit of a red flag. We have had a number of patients go overseas, and I don't know that I've had anything good come of it. We've not had patients have anything bad come of it, but I don't think I've ever seen someone get benefit with it. So I just be a really smart healthcare consumer. Do your research. Ask them where the cells are coming from. Ideally, again, if they've got a peer-reviewed published article, that would make me feel a lot better.
And steer clear of adipose stem cell trials.
Yeah, yeah. I think it's hard because in the MS world, people like Sherry, myself, healthcare providers, all the messers, we don't have all the answers yet. We don't have a cure for MS. And when you're dealing with something like primary progressive MS, where our treatment options are fairly limited, it's frustrating. And as hopeful as we are, and we talk about these great advances, I know that for someone living with MS, it probably feels like things are moving at a snail's pace, and you want something right now. Completely understandable. It also makes you very vulnerable to being taken advantage of. So when we're desperate for treatment options, our son dealt with acute myeloid leukemia and ultimately died as a result of it. And we were in that position. We knew the desperation. You want to do something, but at the same time, you just make sure you're being a smart healthcare consumer, because you can get taken advantage of.
Krista is asking, will this recording be available to us? This is currently live streaming on Facebook. So our public Facebook page, the Multiple Sclerosis Foundation, you can view the recording. After this session, I will be sharing that recording with our 4 private Facebook pages, so you can watch it there. And within about a week, it should be on the Multiple Sclerosis Foundation YouTube page as well. So thank you, Dr. Thrower, for your time. And we are now up to 70 questions. So
Yes, let's look at doing part 2.
I think the part 2 is a great idea for your Ask the MS Expert next month.
Yep, I like
So stay tuned, folks. If you didn't get your questions answered today, keep your eye out. We will be announcing that. And I'm thinking, let's see, that you're probably going to be on September 10th, I would think.
I think so. I think that's
Tuesday,
correct.
September 10th at 4:30. So just tick that into your calendars. Our next, I mentioned this at the very beginning while Dr. Thrower was getting his slides up. Our next webinar is going to be Dr. Aaron Boster answering your questions about MS and symptom management. Some of the questions that are in the queue right now are things that are not related to neuroplasticity or nerve repair, and he can certainly answer a lot of those. So please bring your questions on diet and symptom management and rehabilitation to him next week, or email me, sherry@msfocus.org, and I will send Dr. Karpatkin's email to you so you can ask your PT related questions of him. Thank you all for coming. Keep cool. Have a wonderful summer. And again, happy anniversary, Dr. Thrower.
Thank
You
you
and
very
Karen
much.
just celebrated 39 years.
Thank
So
you.
thank you
Take
so
care,
much.
everybody.